Welcome, everybody, and thank you for coming to our NNE-CTR seminar today, where we'll hear three great speakers talk about transdisciplinary approach to effective health communication. I'm Valerie Harder. I'm an associate professor here at the University of Vermont, and I also been part of the NNE-CTR for the past 5 years, helping to lead the Vermont team in the tracking and evaluation core, and work very closely across all the cores of the NNE-CTR to promote our transdisciplinary research. So welcome again to the seminar. We have three speakers today. The first is Matt Dugan, sorry if I pronounced that incorrectly. He teaches communication, persuasion, media, health, and environmental communication in the Community Development and Applied Economics Department at the University of Vermont. In his prior career as an entrepreneur and in his current one as a teacher, Matt particularly enjoys turning quantitative and qualitative research into effective messaging. Our second presenter today is Kate McAllister. Kate's a UVM graduate of psychology and public communications, worked very closely with Matt Dugan throughout his 3 years at the university. She currently works as an associate account manager with Fuse Marketing on their brand strategy team, overseeing developing and optimizing marketing campaigns for companies such as Pure Leaf Tea and Vail Resorts and Rockstar Energy. Prior to her current role, she started her own social media marketing company called With a Twist Marketing, where she implemented strategic social media campaigns and oversaw project management for companies such as Vans and Fender. And finally, it's great to have Maureen Boardman. She is a clinical assistant professor of medicine at Dartmouth. She's an experienced nurse practitioner with a demonstrated history of working in the higher education industry. She's skilled in clinical research, advanced cardiac life support, nursing, hospital, and basic life support. And she has a master's degree focused in family practice, nurse practitioner from the University of Tennessee in Knoxville. So welcome to all three of you. I have a brief description of the presentation today. Would you like to do that, Matt, or would you like me to do that?
Oh, go ahead, Valerie. Yeah, sure.
Okay. So again, today we're all going to hear about transdisciplinary approach to effective health communications. And it is, as you all know, it's an essential part of public health is communicating to various audiences. Yet the history of health communication has included a surplus of guesswork and wishful thinking combined with a shortage of measurement. So using an NNE-CTR health communication project as a model, the first part of this presentation is going to discuss how and why to use best practices approaches to develop and measure health communication campaigns. And the second part of this presentation will cover best practices in action. So I'm excited to hear what these three have to say. So let me turn it over to you, Matt.
Wonderful. And thank you, Valerie. And thank you for coming today, since I'm guessing that cool drinks on the deck are beckoning everybody. So yes, all together now, transdisciplinary approach to creating effective health communication. That's a mouthful, says Mr. Puffin. So we're gonna try to reward you for coming here today and avoid some of the academies. Put more simply, you know, what the heck is social science and why the heck does it matter? And you'll notice I left out the essential signaling of the academic world. There's no colon here in that particular title. So in case you've always wondered, but never thought to ask, I'll just let you read this definition of what transdisciplinarity is actually all about. I'll give you a few seconds. Okay, so that's still a mouthful. So another way to think about this approach is, you know, humans are complex. We make a lot of decisions every moment of the day. We make them based on a vast number of sort of tools and heuristics and frameworks. We use both logic and facts, and we use just atavistic stuff that's encoded in us from millennia ago, many millennia ago. We do all this amid a swirl of constant inputs and changing mental weather patterns. This runs the gamut from media to interpersonal interactions, so on and so forth. And so the interdisciplinary approach acknowledges all this and tries to take all these variables into consideration. So I'm guessing you have a positive answer to this question. Remember an anti-drug ad starring a fried egg? Just in case you don't, we had an announcer intoning, "This is drugs. This is your brain on drugs." Any questions? Very sort of 1980s dramatic. So was this a successful ad is the question, and if so, why? And here is the troubling part. How do we even describe successful? So today, we're going to tell you a story in two parts. We're going to talk about transdisciplinary thinking in public health communication, the why and the what. And we're going to talk about methods in action. And you're basically it's a story about collaboration, as Valerie was saying earlier. It's based on a project that we have been working with NNE-CTR for over 2 years now. And your humble storytellers, as Valerie has mentioned, it's me. I teach at UVM, CDAE, and I ran a business for more years than I've been a full-time teacher. That business did multimedia production and research and so on and so forth, persuasion basically in the commercial realm, in the nonprofit realm. And Kate, go ahead.
Hi, everyone. I'm Kate. As Valerie has introduced me, I worked very closely with Matt all kind of throughout my undergraduate studies and have been so fortunate as to be able to keep that connection now that I'm starting my career in marketing and kind of continuing my love and interest within the health communication realm in this project.
Awesome.
So.
Thank you. Okay, so we were both part of an NNE-CTR team with a goal. Those students who are crazy enough to actually maintain contact with me do get dragged into these sorts of things. God love you, Kate. The project is to raise HPV vaccination uptake in middle and high schoolers in rural northern New England. And we knew that running a bunch of ads wasn't going to do it. That was actually the model for many, many decades. So why? Well, we know we don't do it that way anymore, even though many practitioners still attempt to do it that way. There are many, many media choices and platforms. Does our target audience have access to the shots? What if it's not a norm among their peers? Are they worried about cost? Do they know about the dangers of not getting vaccinated? Do those dangers seem too far off in the future to be considered? Do they have any sense of efficacy or agency? Do they need parental permission, and so on and so on and so on? And so what we did was we came up with a very transdisciplinary proposal. And we relied on some basic psychosocial theories, social norm theory, social network theory, narrative theory. We proposed a student-led, student-created, peer-to-peer campaign, communication campaign featuring dramatic storytelling. That is, we're using characters as in a play. It's delivered via podcasts on social media over the period of about a month. It directs students to on-campus pop-up vaccination clinics at the end of that campaign. And all along the way, we're collecting data via focus groups, interviews, websites, social media analytics, and clinic visits. And so Kate's going to talk about how this matches with NNE-CTR's major aims. And if I don't advance fast enough, Kate, just tell me my finger is on the trigger.
Will do. So kind of the first aim of the NNE-CTR would be to improve the foundation and support for clinical and translational research in both Maine, New Hampshire, and of course, Vermont. And this project gave us the awesome opportunity to initiate some new relationships and or improve existing relationships. So we also have worked to establish both collaborative and synergistic, oh, excuse me, that's another mouthful, research partnerships along NNE-CTR institutions that will address health problems that are prevalent in the rural populations that are within northern New England. And some of these health problems would include addiction, cancer, cardiovascular disease. And here is how that looks in our project. So some of our recent collaboration, to get all of this done, we had to have experts in a lot of sectors. So some of those were public health, community health, epidemiology.
I lost you. I'm sorry. I lost you. Did my internet blip out?
Yes, I think it did. Anyone
Okay,
else
well,
see me?
I'm back now. So
Happy to have you back.
yeah, where did I
Oh,
leave
we
you? I
can-
apologize.
We can hear you just fine, Kate.
Okay, I was going through the professionals that are within our, that slide. So these are just some of the experts that were in these sectors, epidemiology, biostatistics, social media marketing, oncology, persuasion science, Matt Dugan, media strategy, and so many more. This kind of just touches the surface. So the third aim of the NNE-CTR would be to establish innovative training, mentorship, professional development programs to support clinical and translational scientists within our institution, as well as our community partners. And here is how that happened. So this proposal included funding for students at a variety of different levels, all undergraduate, graduate, and PhD seeking students. And over these past 2 years, this project has engaged a variety of undergraduate social science students at the University of Vermont, one of which will be starting UVM's MPH program this fall, which is super exciting to kind of continue that. Another one is also now working in human resources within the DC area. And the third, who's a recent UVM graduate and social media professional, is also a very important member of the team. So that's me. So definitely a variety has been throughout our team. So kind of tying it back to the fourth aim would be that we're looking to connect community healthcare practices, particularly in these rural areas, with academic institutions, medical centers, primary research networks, and state resources to identify and ultimately and ideally remove these barriers that do compromise rural healthcare access and deliver innovative and community-specific research approaches. So our team has included experts from all of these areas, and our proposal involves working with local health departments in these areas to communicate with their respective communities and ideally provide pop-up clinic to kind of drive some action to increase HPV vaccinations.
Okay, thank you. So I'm going to talk briefly about some goals and philosophies that informed the proposal: acknowledgement of history, integrity, and transparency. So part one, acknowledgement of history. William Faulkner famously said, "The past is never dead. It's not even past." And as if they knew we were going to present this presentation to you, Kate and William decided to go on a antiquated royal tour of the Caribbean this spring, standing up in an antique Jeep and in his military whites and waving to, there's just so much wrong with this picture as well as the tour, and rightly so. It was widely criticized. Not much different from what you see on the left, which is from the early part of the 1900s. So colonialism, we talk about it a lot these days. It's used in a lot of different contexts, but it's basically fraught with notions of superiority regarding other cultures. Not necessarily a lot of news there, but these notions permeate our relationships to this day. And that's where the really interesting and valuable part of this lies. Because these notions are not only about how countries or regions view each other. A misunderstanding of culture leads to disappointing outcomes right here at home. It's all about how we define what a culture is. Because indeed, a culture can be as small as a town or even a neighborhood. One of my favorite studies in ethnography, this researcher studied a few streets in Chicago, known as Teamsterville, and identified a distinct culture operating there. So taking a broader view of health, I'll just let you read. I couldn't say it better myself, so I'll let these researchers say it for me. I'll just give you a few seconds of silence here. So part 2, integrity. I want to talk about another kind of fraught history and a cultural mismatch. So the ad biz, an industry where, to borrow from Garrison Keillor, every child is above average. So some cautionary words. We're doing some self-ethnography here, but this is based on peer-reviewed research as well. And you know, full disclosure, I worked in the marketing communication business for decades, and I've seen a lot of these things happen. So self-ethnography is the academic word for personal experience, but sounds cooler. And if I could put a colon there as well, I would. Anyway, so when health campaigners, you know, people with the budgets, interact with media professionals to create campaigns, different cultures can lead to different aims. Health campaigners want to see results. Ad professionals want to show they've delivered them because that's how you get your next job. So this leads us to, this is your brain on wishful thinking. This is the most famous anti-drug ad ever produced. It was widely seen and praised, and it's been parodied as well. But the effects were never rigorously studied. And even if they had been, an ad by itself is almost never enough to change behavior. That's just all there is to it. Yet, here's the problem. The broad public perception is that it worked. And if you're in the ad industry, why are you going to question this narrative of success? So, quick story. Once upon a time, my former company conducted the research and produced the messaging for a campaign to promote HIV testing. Here's a screenshot from one of the pieces that we put together. A different company, an ad agency, placed the media. That means they bought ad time on various online media channels so that people would go to the website and watch some of our videos that we produce, so on and so forth. Then they produced a media and website analytics report for the client. At the end of this, here is a screenshot from that report, and I'd love to go into it deeply, but this will give you a good example of what I'm talking about. There's a 6,588% increase in site visits, according to this report, based on the work that this agency had done. Here's the rub. How can you have a 6,588% increase in website visits when the site did not exist before the campaign began? I'm terrible at math, but I know that anything times 0 equals 0. I do remember 2 or 3 things from math. So our organization actually looked at the same analytics, you know, website analytics, social media analytics, and drew a very different set of conclusions, one of which was a really important one. The ads weren't effective, but press events were shockingly effective, wonderfully effective. Which brings us to, and actually, I'm going to back up for 1 second because it was so interesting. The press events, and the way we did that is we could simply look at when the website activity jumped up. And a lot of these press events, the way this kind of hooks up with our HPV proposal, it has to do with social norming. And what happened was that a couple of these press events staged by the health department had to do with modeling the behavior we wished to see, which was testing. And a lot of the messaging we put together had to do with modeling the behavior. And that turned out to be quite effective. Okay, part 3, transparency. So I'm going to hand it back over to Kate here to recap NNE-CTR's major aims.
So kind of jumping back into those major aims, as Matt just said, would be to looking to improve the infrastructure and support for clinical and translational research. Also aiming to establish collaborative research partnerships that are ultimately addressing the health problems that are so dominant in rural populations within Northern New England. Thirdly, looking to establish innovative training, mentorship, and professional development programs to support clinical and translational scientists, and additionally also supporting those community partners. And lastly, looking to connect community healthcare practices with academic institutions and medical centers, primary research networks, and their state resources. The way to do this would be ultimately to continually document our steps, explain the process, and better our practices. Otherwise, this could be summarized as a proof of concept approach. When we show that this approach works, success is ultimately going to follow. So ultimately, our job would be to approach communities with both humility and an open ear. We want to use the right frameworks, kind of as Matt was saying earlier about specific neighborhoods and communities do have specific cultures. So this would be from a cultural, theoretical, and data perspective. We want to involve the community. This ideally would be through interviews, focus groups, and surveys. We want to partner with the community to co-create health communication, not just kind of dump it. Measure absolutely everything. Resist the temptation to just declare victory and go home, which would be dare to call the campaign a success, failure, or anything in between based solely on the data. Because it's the only way to know what to do in the next campaign.
All right, and that wraps us up. Thank you, Kate. And I'm happy to hand it off to Maureen.
All right, thank you very much. So I'm going to shift gears a little bit and talk about a specific study that I'm doing right now titled Overcoming Vaccine Hesitancy in Rural Northern New England. And it has to do with, the title is a little bit deceiving because it's not overall vaccine hesitancy, but vaccine hesitancy as it relates to the COVID-19 pandemic and the vaccines and boosters that we have available to fight the pandemic and this disease process. All right. So rural COVID-19 vaccine hesitancy has been a known entity since a poll last March by the Kaiser Family Foundation that found vaccine hesitancy was actually the highest among rural communities. And 21% of all rural residents in that poll said they would definitely not be immunized against COVID-19, compared to 10% of urban and suburban residents. So we've also seen that COVID-19 incidence and mortality is higher in the rural communities. And there's several reasons that I'll go into a little bit more in depth in a later slide why that's related, why that occurs. And then we also saw that a year later in a reported morbidity and mortality that the vaccination coverage with the first dosage for the primary vaccination series was lower in rural areas, 58.5% compared to urban at 75.4%, and that disparities have continued to increase more than twofold since April 2021 in both the original, the primary vaccine series, and now we're seeing that also reflected in some resistance for people getting the boosters. So it's been said that addressing these barriers to vaccination in rural areas is actually critical to achieving vaccine equity and to reduce disparities and COVID-19 related illnesses and deaths in the United States. So some of the reasons why they feel like the vaccine hesitancy is higher among rural populations, it's because they tend to be older, more likely to be uninsured, more likely to have underlying medical conditions, and they live farther away from tertiary medical centers, placing them at higher risk for adverse COVID-19 outcomes. So the other things is with access to care remaining challenging in rural counties, the variation in views regarding the seriousness of COVID-19 infection, and particularly at the beginning of the pandemic when we saw major cities being affected, I think a lot of rural populations felt they were safe because they lived in a rural area and were not in an urban center where people were so close together. We've since seen that that is not a fair hypothesis. So we're working with 3 federally qualified health centers, all in rural New England. The first one is in Maine. It's a Shakopee Valley Health Center. It's in Porter, Maine. Maine has all of the New England states compared to elsewhere in the country have pretty high vaccine at least with the initial 2 or 1 series vaccine, have pretty high dosing. However, all the rural areas that we are working with have a lower vaccine rate than the statewide rates. So that just to be said. So in Maine, 90% have received 1 dose, 79.5% have received 2 vaccinations, and 44% have received 1 booster dosage. In Oxford County, where Shakopee is located, 78.5% have received at least 1 dose, 63.6% have received 2 complete doses, and 36% have received at least 1 booster. Coos County Family Health Services is in 3 offices, 2 in Berlin, New Hampshire, 1 in Gorham. So New Hampshire numbers are a little bit lower. 73, almost 74% have received at least 1 dose. 63 have received the 2nd vaccination, and 29% have received 1 booster dosage. In Coos County, 65% have received at least 1 dose, 59% or 57%, sorry, have received a 2nd dose. And I could not find New Hampshire breaking down data for the booster dosage anywhere. So that's why that's blank. The other 2 states I was able to find that information. New Hampshire, I couldn't, try as I might. Little Rivers Healthcare, which you can see 4 offices, Bradford, East Corinth, Newbury, and Wells River. Vermont has an 88% statewide vaccination rate for at least 1 dose of the vaccine. 82% have received 2 doses, and 68% have received a booster dosage. Orange County, a little bit lower, 81% have received 1 dose, 75% have received 2 doses, and 65% have received 1 booster dosage. All right. So we are surveying patients ages 25 to 65 at all of the federally qualified health centers who are vaccine and or booster hesitant. Our goal is to survey 200 patients from each federally qualified health system, and patients are receiving a $25 Walmart gift card for the completion of a survey that should take about 10 minutes. It's on an iPad, and they're being identified in the offices if they are eligible or not, and given the chance to just fill out the survey while they're still in the exam room or the lobby. At the same time, we're surveying clinicians in the 3 Northern New England states via the Dartmouth Northern New England Primary Care Research Network listserv, the Northern New England CTR listserv, and the goal is to survey hopefully 200 clinicians from each of the 3 states, and they are also receiving payment with an Amazon gift card. And then we plan to do some more in-depth interviews. We're hoping for somewhere around 10, I put 10 to 15. I would hope a little more clinicians from each of the 3 northern states about their personal experience with COVID-19 vaccine hesitancy. So I just listed some questions that I thought might be relevant from the survey to try and figure out why people are vaccine hesitant. You know, are they concerned about side effects? Is it because they're young and healthy? Are they under the impression that because they've already had COVID-19, they don't need to be vaccinated, or religious reasons? We also are talking about information regarding the safety and effectiveness of the COVID-19 vaccine and where they get their information. One of my colleagues, who's an infectious disease specialist, says he can almost always tell where people are watching their news depending on what they answer when he asks them about their vaccine and their interest in the vaccine. But there are a lot of websites and social media that are spreading disinformation about the vaccine. And still people are very fearful because they believe what they've read is true. All right, and then going to the patient survey, we also want to see if people believe that their healthcare clinicians are helpful in their decision making. And are they turning to them to ask the questions, or are they relying on these outside sources? And do they feel that their healthcare clinician is a reliable source who will help you make an informed decision? I had one patient who told me, well, of course you're pro-vaccine, you're in the medical profession, you have to say that. So it's like, well, no, I don't, but so, and then we're asking the clinicians some questions about them, about their patients, about do they routinely ask their patients about vaccine status and booster status, and if they're offering the ability for their patients to become vaccinated, and which vaccines are they offering, and are you helping patients if you're not able to give the vaccines at your healthcare site? Are you helping people find a vaccination site? Because that's been a big issue in rural areas of people having to travel pretty far for a vaccination site. All right. And then just looking at what percentage of their population is vaccine or booster hesitant, and what the most common reason is, again, addressing kind of the same questions in parallel that we were asking the patients. So we changed the way we were going to do the intervention, building on previous research. There was a NNE-CTR pilot grant, the development of messaging to encourage COVID-19 vaccine uptake among rural Americans, that was performed last summer by Dr. Elizabeth Jacobs and Dr. Kathleen Fairfield. And they were looking at rural vaccine hesitancy in Maine. And so one of their findings was that vaccine hesitant patients are overall very distrustful of anything branded from the government or the CDC or other federal or state agencies. So we changed our original intervention from an informational video citing CDC data on the importance of COVID-19 vaccinations to testimonials from the healthcare center staff members. And we have these testimonial sheets that have quotations from not only physicians, but nurses, front desk staff, care coordinators about why they were personally vaccinated. And so this is the sample of the testimonial from Coos County Family Health Services, and it identifies the employee and their role within the health center. And it's interesting, I don't know where people get their television, but New York State, one of the TV stations we watch, is currently running a campaign ad for pediatric vaccinations that is very similar, where they have a bunch of pediatric providers on there talking about the reasons why they had their children vaccinated. So I thought that was interesting when the ad started running. I think about a month ago, maybe 6 weeks ago, I saw the first one and thought, oh, somebody else had that idea. So
I'm going to interrupt and say that is an incredible ad, because you have male and female, and you cover every age group of physician, and you cover obviously folks with very, very different ethnic backgrounds. It's very powerful.
yeah, and we're hoping, like I said, and it's at the local level. So each one of the health centers has, you know, the testimonials from their own employees. And so we're hoping that bringing it down to that community level, maybe not to the block level that Matt was talking about, but definitely the community level in your local health center will, you know, inspire people. to think a little bit more about getting vaccinated if they have been hesitant. All right. And that's what I've got. I didn't put anything at the end because I wasn't sure if I was going to be ending the discussion or not.
That's great. Thank you all. Matt or Kate, does it go back to you?
We have no back to us. We
Okay.
are now open for questions, and I'm actually really proud of Kate and myself, and of course Maureen. We all stayed under our time limit, so we actually have extra time if you need it.
Oh,
I
good. I
guess.
see some
Ask-
questions. Got a hand raised from Daniel.
Hello, hi, thank you. This was extremely interesting and eye-opening for those of us who have no particular experience in how to do this kind of public health messaging. I had one really small specific question about the COVID vaccine project, and then a much more general question.
Oh, you just muted Daniel, by accident, maybe.
No, I
Oh.
didn't touch a thing, it's
No.
magic.
That
Where
was
did-
me. Sorry, I was muting myself. My apologies.
Oh,
Where should I start? Where did I lose?
oh, just the last sentence.
So I was saying I had two questions, a specific one about COVID and a more, so my specific one about the COVID study is, why stop at age 65 when one of your hypotheses was that the reason why there was a lower vaccination rate in rural populations is because they're over 65?
So Dan, that's my fault. I actually misspoke when I did that slide, and I was going to go back and correct myself, but you caught me. So that's why there are worse outcomes in rural populations, is because it isn't actually the vaccine uptake in the over 65 group is some of the highest across the 3 states,
Right,
like
okay.
at 95%. The reason why we are worried about rural populations is because they have a higher group of elderly residents.
Right.
And so-
That makes more sense for that slide. Thank you. But my more general question is this. I can see how the strategy that you're teaching us about would be particularly effective when the behavior change that you're trying to accomplish is something very specific, like get the vaccine for COVID or get the vaccine for HPV. One could make an argument that the greatest public health threat that we're experiencing now is climate change. And there are a number of organizations that are trying to frame, trying to help people understand that the threat of climate change is a health threat, is a public health threat. The behavior change that's required to address that is very, very broad, going from personal choices in how you live to contacting legislators to advocating for policy change in the streets, on and on. How do you apply these principles to a very broad public health problem like climate change?
You want to go first, Maureen, or?
I'll let you.
I love that question, Dan. And you may not love the answer, but I love the question. It's actually what I spend my life obsessing about. It's what I teach about. It's what I spent years in business working on. There are common principles that you use, persuasion science techniques. There are no home runs. You can't hit a grand slam with no one on base. What you do is you look at every situation individually, differently, and you attempt to segment your audiences as much as you possibly can, because communicating to each individual person is too expensive. You bring in a different set of persuasion techniques. Social norming is one of my favorites. It goes all over the place. It just works well, but there are other ones you can bring in, and there are many. There are people who get their PhDs in you know, in persuasion. So there's a lot of science out there. And you do it an intervention at a time. There's one, just to touch on climate really briefly, I could go on all day and I promise I won't. You know, you may have heard of the 6 Americas study that Ed Maybach and other people do, you know, the big climate study they do every couple of years. One of the most compelling things that ever stuck out to me there was that that framework has been used to literally talk about public health. So you're not talking to, say, hard right people who don't believe in climate change, who don't believe it's happening or whatever. You don't talk about, here are the facts, let me hit you with more facts. You talk about public health effects and you find those commonalities. So I'm always thinking of Venn diagrams in terms of bringing those audiences together too. That's not an entirely satisfactory answer, and I recognize that. But if you think about the history of the ad world, where everything's a swing for the fences, and then everything is a, oh, look how much we did, whether you did it or not. If we could actually rerun the last 40 or 50 or 60 years, when we really had a handle on this persuasion science and do a lot of things differently, we'd have made a lot more progress by now. So I just project into the future 10 or 20 or 30 or 50 or 1 year, using the right techniques and you know, kind of pick off these challenges one at a time.
Thank you for your questions. Renee, I see you have a question, your hand is raised.
Yes, I wanted to just thank everybody for their presentations, and I'll try not to sound too excited, but I kind of feel like I found my peeps. So my name is Renee Wolf. I'm a physician. I work in Maine. I work with the Division of Preventive Medicine on some community health initiatives. Maureen Johnson is on this call too. She's our program manager. And we've really, we work predominantly with immigrant populations and people who are non-English speakers over all the issues that you've addressed, whether it's, you know, vaccine hesitancy or other healthcare issues, public health stuff. And we've really been focused on doing things in a co-produced way. So our initiatives are intended to be co-created and co-produced, and there are some challenges there. But we really are trying to promote dialogue between healthcare systems and the receivers of that care, sort of based on the belief that if you want your intervention to be effective, you need to know what people need, and you need to be able to ask them in culturally appropriate ways. And so we've focused on creating some platforms for dialogue and using this model of co-production. We have a series called Ask the Doc, which we do in 3 languages. Basically whatever people want to ask about. Sometimes we get the topic ahead of time, sometimes we don't. It's been fairly COVID centric in the last couple of years. We've been doing it for over 2 years. We've reached over 700 immigrants where they just can ask questions of a doctor. And so we've learned a lot from that. And we also did a Project Echo series where we've done 10 sessions, or we've done 9, our 10th is coming up, that's co-produced addressing barriers to healthcare that immigrants face. And the topics were chosen by focus groups with immigrants. They're led by community health workers and community leaders. And we flipped the paradigm so that the community members are the teachers and all the people who are providers and access to care people and are learners. But one of the interesting thing is that it is transdisciplinary. We have about, 15 to 20% from all different kinds of disciplines sitting around a table talking about why mental health is difficult for immigrants, or, pick your topic. And I'm getting to my question. I'll be short, I promise. The underlying current, which I think is also related to the climate issue, is trust. That's what we have seen in every single initiative that we've had, is that there is such distrust. And I think that's what we see as the biggest barrier. And so that's why we focused on creating relationships, because we think that it doesn't matter whether we're talking about climate change or, getting your kid vaccinated. If there isn't trust, then we can't have influence. But the other thing that we've faced is structural racism and institutional colonialism. And I wonder if any of the people on this call have a good measure for a metric for measuring trust, because we've looked at a lot of them and we haven't found anything that we think is really good. Like, how do you measure if you're gaining someone's trust so that you can have sort of relationship building. And if anyone has any strategies on dealing with institutional colonialism, which I must have just been sort of living my life in a bubble, because I did not realize that not only are the policies that are historically present really colonialist, their current formation and implementation is quite shockingly so as well. Thank you.
I love your sort of trust barometer. I'm guessing there's something out there. I don't know the tool. I haven't used it personally. I'd leave that open to anybody else. Did anyone use the tool?
No, I haven't used a tool related to trust. I'm sure probably, I would think there would be one out there, but it sounds like, Renee, you've done some research and have not found one that's satisfactory.
I found some fuzzy ones that don't, that I'm not entirely happy with. I'm looking for a better one.
You know,
I will ask around.
measuring trust is really key. I think the perhaps unique challenge that we've had over the past several years has been not to be able to go and to persuade people to be able to engage in healthcare practices that are going to be to their benefit, vaccination, but we've had a tremendous amount of misinformation that we've had to go ahead and to counter. So it's not just confidence in science, it's what constitutes credible science. I don't know how you measure that, but that's something that unquestionably we've been having to deal with. And I think it's going to take a lot of effort to be able to restore confidence in the voices that people should be listening to.
Yeah, I agree. And we measured some of that credibility in terms of how many people showed up to get vaccinated. And, you know, other things, if they come, we did it in terms of meaningful community engagement metrics as an indirect measure of trust. And I can tell you that we've learned a lot. I mean, I'm not in a white coat on a podium, just, you know, throwing information in one direction. I'm sitting in a room of people who speak a different language than I do, make jokes in a different language than I do, completely out of my element, trying to figure out why they're afraid of going to a funeral and having to understand it's because they've lived through Ebola, you know, or whatever.
But what I'm also hearing that's been successful is asking the communities, how do we persuade you? Rather than going ahead and coming with an academic perspective of how it works. And I think that probably has been beneficial.
Totally. And I will say that our Project Echo series is the most successful Echo series Maine Health has had. And I don't think it's because we're wonderful. I think it's because there's a desperate need for this dialogue. I mean, we have between 60 and 100 people to each one of these Zooms. And I think it's because we've hit on something that people and our, you know, it's been a lot easier to get community members to come to the table than it has hospital members to come to the table, not surprisingly.
Oh, sorry.
No, go ahead, please.
No, I was going to say, I think it's really hard to get at the level of trust when, you know, you're debunking or talking about the having to go in and face, like Gary was saying, this misinformation that they've been fed. I think that as a clinician, you end up walking a really tight line between alienating people, because what they've come to the table with, you're trying to say this isn't true without, you know, and convince them that the vaccine is safe, or that's been my tightrope, while trying not to offend where they're coming from or what they've read or what they're bringing to the table with them. So I have found it a very hard place sometimes to be, to, you know, walk that line between, you know, oh my goodness, you went down that rabbit hole, or, you know, kind of to put it in such a way that, well, here's some, you know, this is how I feel, this is why I was vaccinated, this is, you know, I had my children vaccinated. I wouldn't do it. I would not have my children vaccinated or vaccinate myself if I was worried about any of these horrible side effects. And just bringing it back to the one-on-one, me in the room with that person.
I mean, we've been amazed at how we've been able to do that over Zoom. In fact, Zoom was actually a barrier lower, which was kind of interesting because people could come in anonymously. So like our community health workers ran it and they could text their question to the community health worker. They could come in and black themselves out and not identify themselves. And we saw that over time, there were more videos and more people with their names. And so we took that as another sort of indication of trust. And, the vaccination thing, your experience is exactly what we have. There is a fine line. We ask a lot of questions, but I think one of the difficulties is that it's been a moving target and all of us form an initial understanding. And it's really hard to deviate, from our initial understanding of either the pandemic or the vaccination. But when you have a moving target and then you have to explain, well, yeah, you're out 6 months from yours. You're not that protected as you think. It's that makes it difficult as well, which is, I think, we do these monthly in these 3 different languages. And so we found that you got to have like the same people doing it so that there's a consistency, so that the relationship is built. And so that when the target changes, it's not because you're a different person giving a different message. It's because, the pandemic changed again.
But that's so hard to explain, to the average person, particularly in rural settings, because they're looking for answers they could have confidence in. And what we're looking at is works in progress and moving targets.
Exactly.
Yeah, I think there's a bridge there that I keep waiting for so many different fields to grow up into their maturity. So if you think of your traditional PR flack from whatever, 80 years ago or whatever, or if you think of the boilerplate stuff you get from so many companies and politicians, every word is very carefully crafted. Well, it's communication professionals, the good, bad, and the ugly of the whole field, I guess all your perceptions aside, the hugely bright side of it is that the way PR is being taught nowadays is as a much more research-based, much deeper, much more conversation-based field. And so COVID communication drove me nuts. I'd watched it closely for 2 years because that's my place. As soon as somebody said something, say the CDC, somebody went to some contrarian researcher somewhere, completely legitimate, and that became the news, and that becomes the dispute, and that becomes the dialogue. More unity, as much as Fauci is so interesting to listen to and so smart, much more of a, there needed to be a gatekeeper on Dr. Fauci from the perspective from the perspective of too much information, essentially. And so I would also say I would also suggest anyway, that a lot of these issues can be addressed by unity of messaging and just being consistent. And it sounds a little bit like propaganda. Yes, it does. And I think we avoid it all for that reason. Oh, we can't do that. But considering all the different platforms that are out there, considering how much stuff is retweeted, reposted, boiling messages down and keeping them honest and true and limited is the answer to, it's the thing that the communication world, the PR world can contribute. And before we run out of time, I also just want to super briefly address your other comment there, Renee, which has to do with sort of like all the institutional issues that we're grappling with. And the other place I'm waiting for us to get by is I'm waiting for us to get through the cancel culture aspect of it all. You screwed up, therefore you have to, whatever, do penance, 20 push-ups, lose your job, and get into the really interesting stuff about, look at that. Like, you have gendered organizations as well. I mean, I teach a public administration class for the master's program at CDAE as well. And we actually spent a lot of time this last semester talking about, look at all the language that you find just in any organization. Look at the work habits that you find in any organization, that sort of unspoken cultural stuff that people react to, which actually can go back 50 or more years and be largely male dominated. And look at the negative effects it has on careers, on salaries, on guilt about leaving the office to go take care of kids or whatever. So, and I think that once we're past the sort of you screwed up, we just change those things one thing at a time once we see them. And I do see a lot of hope there, because that's literally what the public administration area of inquiry is working on doing. All the theorists and practitioners in there are identifying these things, and they're taking a good evidence-based look at them. So there's hope there too.
Thanks, Gary. Do you have another question? Your hand is raised.
No, I didn't follow the instructions and didn't lower my hand, but
Others with more questions? This is a great conversation. Okay, well, thank you again. I want to thank Matt, Kate, and Maureen for your time and your excellent work, and appreciate you sharing that with all of us today. And if anyone has any questions or want to contact some of our speakers, please reach out to Sheila, who sent around the invitations, and she can put you in contact with them.
Yeah, please do. Good to see you all. Thank you very much.
Yes,
thank
thank
you
you.
very much.
Thank you.
Thank you.
Bye-bye.